This week on the BackTable Podcast.
Alliance A02 and 806, actually, we just got notification this week that it closed to accrual, so they met their accrual target. So yes, I think a lot of people feel like that's going to answer the question definitively. The question is it going to change practice? Is it going to convince surgeons who believe that there's a role for neoadjuvant therapy for patient selection, not to use it? I don't know the answer to that. And then PREOPANC-3 is essentially the identical study that's being conducted in the Netherlands. And so I think the readout of both of those will be informative. It'll be interesting to see if they're consistent. But I think that those will give us some interesting information.
Hi, welcome to BackTable Tumor Board. This conversation today is going to be an episode about pancreatic cancer and specifically management of localized pancreatic cancer. So we have another podcast episode where we're discussing management advances in advanced and metastatic pancreatic cancer. And this one's for the other subset of folks who are diagnosed at a potentially earlier stage. So my name is John Mizrahi. I'm a GI medical oncologist at Ochsner and MD Anderson in New Orleans. And I'm lucky to have here today a guest, Dr. Rebecca Snyder. And Dr. Snyder, you want to introduce yourself?
Sure. I'm a surgical oncologist at MD Anderson in Houston, Texas.
Well, welcome, and I appreciate having you and your expertise on. So we can start with just like a quick background to set the lay of the land here. So, as we all know, pancreatic cancer is a challenging disease to manage and treat. And one of the reasons is that, unfortunately, most patients are diagnosed at a pretty advanced stage. So really only 15 to 20% of our patients that we typically see at time of diagnosis are diagnosed with a localized, potentially resectable disease. And the incidence is continuing to rise, and we're seeing some data that particularly younger, even female patients seem to be having higher incidence as well and higher rates of diagnosis. So for the sake of this conversation, we're going to talk about patients who kind of fit in the earlier part of the spectrum of their malignancy. So patients with resectable, borderline resectable, and locally advanced pancreatic cancer. So Dr. Snyder, do you mind helping me kind of do a rough, without going too much detail, just definition of how you think about those different categories and how we put patients into those buckets?
Yeah, absolutely. As a surgeon, that's certainly the first thing that I do in my evaluation. And so that's obviously based on imaging. And it's really, at this point, based completely on tumor anatomy. So we're looking first at the tumor anatomy, and that's the relationship to the mesenteric vasculature. So tumors that have either no contact with the mesenteric veins or just abutment less than 180 degrees are considered anatomically resectable. Borderline resectable is more than 180 degrees on the vein, and then locally advanced are patients who have an unreconstructable vein involvement and arterial abutment or encasement that's over 180 degrees.
In your practice, because obviously, at MD Anderson, things are very specialized and your radiologists are very much looking at these all day, every day. Is that a determination that's made typically by you, the surgeon? Is it something that's done in tumor board? Is it something that's readily, you can glean that directly from the CT scan report? Because I think that's something like when you're looking at community practice, it's not always clear how you're going to make that definition.
Absolutely. It's really a surgeon-based decision, honestly, and so much depends on the quality of the imaging. So it's really critical that these patients have a specific protocol imaging done that's a CT with fine cuts. You need at least 2.5, which really is not enough. Even 1.25 millimeter slices, and then at least 2 phases of contrast. So you need an arterial phase and then a portal venous phase. So you really can't make that assessment on like your standard, ER CT scan. And we do use a radiologic template that our radiologists use that comments on each individual vessel. And that's helpful, but it can't replace the surgeon's own review.
Yeah, I often find that I feel like no offense to our radiologists, but our surgeons are the best radiologists. And I learn a lot just from sitting with them as they go through the scan and picking up a lot of these nuances of anatomical, but also just some subtle soft tissue changes that maybe weren't initially caught when the first read was made. So when you're seeing these patients, talk to me about the multidisciplinary management up front. So, we'll get to how we treat all these different buckets, but who are the stakeholders and who are the patients seeing as part of this multidisciplinary treatment in these localized treatments?
Yeah, we do a pretty comprehensive analysis of kind of everything about that could go into that decision around surgery for these patients. And so we sort of see them first. We're the first step. But the things that I'm thinking about are not only the tumor anatomy, but also the biology of the tumor. And that's specifically reflected in the CA19-9. We don't have a lot of other good biomarkers at this point. But what their baseline 19-9 is after biliary decompression is really informative in terms of the likelihood of there being occult metastatic disease that might not be seen on imaging. So that's certainly one aspect. And then sometimes I'm seeing patients that have already gotten therapy. And so trying to understand what's been their response to date is important. And then also their kind of how healthy are they? What is their performance status? What are their medical comorbidities? At MD Anderson, we use this kind of like ABC category. So the anatomy, the biology, and then the patient's condition as a way to assess their resectability. And all of those things are important, not a single, you can't just evaluate one of those in isolation. And so I do that initial assessment, and then we often will engage colleagues in internal medicine and geriatrics if we have medical issues that we need to optimize. We also routinely engage with nutrition because many of these patients have become malnourished during their kind of initial symptom presentation and diagnostic workup. And so we need to do some really intentional work around improving their diet. A lot of them have exocrine insufficiency and need to be on pancreatic enzymes. And then obviously many are diabetic, and sometimes that's a new diagnosis and it's not well controlled. So we want to make sure we're addressing all of those things in terms of nutrition. And actually, we also are seeing a increasing incidence of pancreatic cancer in patients who are obese. And so we have another subset of patients who we see who we actually really need to address weight loss in order to be able to consider surgery as part of their therapy. So the nutrition piece is really critical. And then also we want to assess their fitness, their performance status. And many patients are completely sedentary at baseline, or they've become sedentary during their workup and as they become symptomatic. And so trying to address their fitness and activity level is also really key.
Thank you. That was a great overview. And I think the other variable there is, if a lot of these patients are getting neoadjuvant chemotherapy, and sometimes that can be working against their fitness level as well. So when you guys do some of this like nutritional and I don't know, we call it over here like prehab, where you're trying to kind of get them, prehabilitated before the surgery. Do you do a lot of that during their like neoadjuvant chemo, or is it usually in that break between they finish chemo before they go to surgery potentially, or is it a combination?
It's absolutely from diagnosis until planned surgery. So, and honestly, the duration of neoadjuvant therapy depends as much on their response to treatment as it does on what kind of progress we're able to make in terms of their fitness and their nutrition. So we engage with nutrition, and we have physical medicine rehab department here who will see patients for prehab, and we engage with them right at diagnosis. And then when we do our restaging visits, we have patients follow up with them at each of those visits as well. So we make sure that we're addressing that throughout the whole period of time. I kind of have a spiel that I give patients, which is essentially that during chemo, it's every other week, and you're allowed to, feel bad and not exercise for the couple of days, but then you have to get back at it. And I essentially ask each patient who we're thinking about surgery for, I ask them to be able to walk 30 minutes a day. Like they need to be able to walk 30 minutes a day without stopping to be able to undergo a pancreatectomy.
I like that. I think something very like concrete like that is helpful. It's not just like, hey, you need to exercise more, but like, hey, here's like a very specific thing you need to be able to do. And if you can do this, it's going to bode well for what we're about to do to you. I like that a lot, actually. I might steal that for my patients. Yeah, I think the only other thing I would add to it, and again, you were very comprehensive, is germline testing we do. And I mean, this kind of can be done at any point in their continuum of care, but we try to at least get that rolling early because it can have some implications for treatment, actually. Perhaps not surgically, but medically. So, for example, we know that 10% of patients will have, germline alterations that increase the risk. So, germline BRCA mutations, 5 to 7% of patients, and that has potential therapeutic implications for chemotherapy, right? So we know platinum agents are particularly effective for patients with HRD mutations and BRCA in particular. And also there's some studies looking at, for example, maintenance olaparib after completion of adjuvant therapy. So it has some relevance for potential clinical trial enrollment too. So we try to get that checked pretty early as well. And then really the rest of the molecular profiling for next generation sequencing as we're looking at some of these potentially targeted therapies, moving them into localized disease. And we could talk about that a little bit later, but something else I would add that we're trying to check on earlier in their disease care.
Absolutely. I agree, John. We do the same. And then we have started, in the last couple of years, we've started sending an NGS panel on the FNA. So we do an extra pass at the time of their EUS FNA, and we've been able to get a pretty good yield on that so that we get both the germline results as well as the somatic testing results, which isn't really informing neoadjuvant therapy at this point in time, but I think we all anticipate it will at some point.
Yeah, no, I totally agree. That's good that you're able to get that from the FNA. Sometimes the yield isn't that high, but definitely if you're making it intentional and saying we're going to send that extra material to do it. So let's dive in a little bit into like each of these different categories of patients, because while there's overlap in how we're generally managing it, they are really distinct populations. So historically with a resectable pancreatic cancer, the standard of care for quite a while has been upfront surgery. Obviously, there's variation in practice, but if you look at kind of what the historical practice has been, it would be upfront surgery followed by 6 months of chemotherapy. And because of the PRODIGE trial, that's Folfirinox. We know that the therapy that has been proven for the adjuvant setting with the longest overall survival would be Folfirinox. So, but even that whole statement is a little bit controversial. So talk to me about what your practice is at Anderson for that resectable category, and maybe that's not the approach you take and why that might be.
Yeah, so we historically have been early adopters, if not, trendsetters, and this predates my time here, but in neoadjuvant therapy. And the reasoning is not because we're trying to shrink these tumors to make them more resectable. Obviously, when they're already resectable, you're right, you could operate up front. But what I think neoadjuvant therapy proves to be a really useful tool for patient selection, number one, because we all know that pancreatic cancer is a systemic disease. And so many of these patients have occult micrometastatic disease that we can't measure currently with imaging. We may or may not be able to really know their risk in terms of CA19-9, as some patients are non-producers, and so we don't have a tumor marker that's reliable to track. We don't have enough information yet about things like ctDNA, but we do know that patients recur after this operation. 80% of patients recur. So it is very likely that many of these patients have occult disease that we can't appreciate. And so some period of time giving them systemic therapy will treat that micrometastatic disease. One of the other reasons that we favor giving therapy before surgery is that many of these patients struggle to recover from this operation. It is obviously a big surgery, and there's significant morbidity associated with it. The average age of the patient that I see with pancreatic cancer is around 70. And so these are older patients already. And so it can be difficult for them to recover enough from surgery to then be able to initiate adjuvant therapy. And we've seen that time and again, both in our practice and even in clinical trials, that many patients never get on to adjuvant therapy. And so if you haven't given any therapy before surgery, then you've basically treated a patient with surgery alone, which we know is inadequate. And so that's the second aspect of it. And then the third aspect is, as I mentioned before, many of these patients do need some prehabilitation, because while it might be possible to do surgery, are we going to have a good outcome, both oncologically and in terms of that patient's quality of life, if they're not fit and well enough for surgery? And so it gives us a built-in opportunity to improve upon that so that we can have a better outcome from an operation. So my practice, and I'd say probably of most of my partners here, is that we in most patients, not every patient, but in most patients, we will do some course of neoadjuvant therapy. How long that is sort of individualized for each patient. And so we restage every 2 months. We see them back and reassess with imaging and tumor markers. And depending on their response and their fitness, then we make an individualized decision.
No, thank you for explaining that. And I mean, I'm in agreement, not just because we're sharing this podcast together, maybe because I trained at MD Anderson also. So that's where my bias comes into play. But I definitely drink the Kool-Aid, if you will, of neoadjuvant therapy. I think you hate to see it when it happens, but when patients do develop, or at least we find their metastatic disease during that preoperative therapy, you're saving them a potentially futile surgery. And that is, one potential benefit you do see from time to time. And then, like you said, so many patients that if they get upfront surgery, we know that a high percentage of them don't make it to adjuvant chemotherapy. And as you said, that's not optimal therapy for them. So we do the same thing here. Our resectable patients almost exclusively get neoadjuvant. Curious though, is there like a particular patient type or a scenario in which you would say upfront surgery is the way to go? I mean, one example is if a patient has like biliary drain and maybe they couldn't get a stent in an ERCP, and that's someone who we think of quality of life issues and chemo is going to be hard. That's a scenario which we've done upfront surgery. Or, do you think a patient with like a tail of pancreas, like a distal pancreatectomy, so straightforward, maybe I'm just throwing examples out. Are there patient populations where you would favor actually doing upfront surgery?
Yeah, it's a great question. There are. I think that for patients for whom obviously we can't get a tissue diagnosis, then, and that may happen because the sample's non-diagnostic, or they had pancreatitis, with the attempt, or they've had a gastric bypass. And so there can be a variety of reasons, but that would be one. I think another one is obviously, the patient would need to have a normal or very near normalcy in 19.9. I would not feel comfortable operating on anybody up front who had a 19.9 over 100. To me, that's not appropriate. And then it also depends on the patient. So a younger patient who is very healthy that could get through the operation, particularly as you mentioned, a distal pancreatectomy compared to a Whipple, I'd feel more inclined to consider upfront surgery. But for most other patients, I find myself thinking, will I be kicking myself if they have a complication and I've not given them any therapy? And if the answer is yes, then I would favor doing therapy first.
Yeah, no, I think that makes total sense. And there are multiple ongoing and studies that we're kind of waiting on results from that are looking at this very question, right? So the biggest one in the US is the Alliance study that's randomizing patients with resectable pancreas cancer to upfront. This is with Folfirinox. So the study's with Folfirinox for 4 months, followed by surgery, followed by finishing 2 months of Folfirinox, versus upfront surgery, followed by 6 months of Folfirinox. So, eligibility for that, patients have to be eligible for Folfirinox, right? And then have to be resectable patient population. So, there are other ongoing studies, NORPACT-1 is one, and, trying to answer this very question so we can have prospective data, because I think for many years it's been something that has some institutional and geographical variance in terms of how it's done, but to have, high level data, I think would be pretty impactful to providing, the same care for all patients. I don't know if you have any specific comments on that.
Yeah, so the Alliance 802 and 806, actually we just got notification this week that it closed to accrual, so they met their accrual target. So yes, I think a lot of people feel like that's going to answer the question definitively. The question is it going to change practice? Is it going to convince surgeons who believe that there's a role for neoadjuvant therapy for patient selection, not to use it? I don't know the answer to that. And then PREOPANC-3 is essentially the identical study that's being conducted in the Netherlands. And so I think the readout of both of those will be informative. It'll be interesting to see if they're consistent. But I think that those will give us some interesting information. I think the NORPACT-1 that was published, I have some concerns about that data. The patients in that study were randomized to a very short course of neoadjuvant therapy with Folfirinox compared to surgery first. And of the patients that were intended to get neoadjuvant therapy, only I think about 40% of them did not complete the 4 cycles, and a significant proportion, I think around 20%, didn't even get a single cycle. And so, they demonstrated inferior survival in the neoadjuvant therapy arm, but I think that it was a small study and the actual duration and delivery of neoadjuvant therapy was pretty limited. So I'm not sure that we can really draw conclusive evidence from that.
Yeah, I remember that study being the oral for that. I guess was it ASCO last year, and it was interestingly received. I'll say that it didn't sway anyone. If you were a believer in neoadjuvant, you continue to do neoadjuvant because you saw the faults, and if you weren't, then you saw the data and you're like, how can you argue this is inferior? So
right.
It was kind of interesting, but I think did not answer the question. I agree with you.
Yeah.
And I from a chemotherapy perspective, there's we still Folfirinox or modified Folfirinox, I should be more specific, is still considered the gold standard. It was interesting. We have data from SWOGUS 1505, which is a small study, but it randomized patients to Folfirinox versus Gemcitabine Nab-Paclitaxel. And interestingly, there really wasn't a big difference in terms of survival. It was very small, and there was some indication that perhaps even the Gemcitabine Nab-Paclitaxel had a better pathologic response. But it is, I think, most people would agree, medical oncology field, and I would think in the surgical oncology field, that we think that the triplet is still the superior regimen, but it's not as cut and dry, I think, as we maybe perhaps once thought.
I think that's fair. I think the SWOG 1505 was not powered to compare the two. They were each being compared to historic control, but it does, I think, give you some assurance that Gem/Abraxane doesn't appear to be inferior, and we use that fairly regularly for older patients who we don't think can tolerate the toxicity of Folfirinox. So I think we feel pretty comfortable using either.
Yeah, I totally agree. And I think, I don't know what our breakdown is here either, but I would imagine that a decent percentage of our patients, if not more than half, get Gem/Abraxane because, as you mentioned, this is a cancer of older folks. And, even the ones who get surgery, tend to be older, and not everyone's fit for Folfirinox. So we use a lot of Gem/Abraxane perioperatively. Going into the next bucket, which I think is a little bit less controversial, is borderline resectable. So we've already talked a little bit about the definition on the spectrum of resectable with limited to no vascular involvement to locally advanced, where you have really encasement of major arteries or non-reconstructible venous structures. Borderline resectable is kind of in that in between. And, really the standard of care is to do neoadjuvant chemotherapy there. So I don't know if you have anything to add to that, but I think that's pretty well established.
Yeah, I would agree with that. My partner, Dr. Matt Katz, has done a lot of work in the borderline resectable space and was the lead investigator for AO21501, which was an alliance clinical trial that randomized patients to either neoadjuvant Folfirinox or neoadjuvant Folfirinox plus radiation. So not to bring radiation into the mix too early, but I think it was an important study because it did demonstrate a pretty impressive median survival of 67% at 18 months in the patients who got neoadjuvant Folfirinox with borderline resectable disease. So yes, we obviously treat those patients with chemotherapy and then selectively use radiation kind of on an individual patient basis.
Well, let's jump into it. You brought up radiation. I didn't know if I was ready for it, but let's say from your perspective, and we don't, we can do data or just kind of in your clinical practice, are there specific patients that you really do push towards getting preoperative radiation? I know at MD Anderson, at least when I was there, it was pretty standard to give a lot of patients, particularly when you're talking about borderline resectable preoperative radiation. I think at the time I was there, it was a lot of doing patients over 3 weeks and about 30 or 15 fractions, I should say. Is that still the case? And how do you consider who needs that radiation, and who do you think would benefit from it versus someone who maybe, can go straight to the OR after chemotherapy?
Yeah, I think we've swung a little bit back the other way. And again, I think we use different fractionations depending on the individual patient scenario, and we don't always use radiation. And so I think, from an evidence standpoint, we don't have any clinical trials that radiation, in the neoadjuvant setting improves overall survival. But we do feel like there is a role for some patients In my personal practice, I use radiation for several reasons. One is when I have concerns about tumor biology and I'm trying to give some test of time. And so maybe it's a patient who's had a response to chemotherapy, but their CA19-9 is still elevated. It's 150, and that's the lowest it's gotten. And so I feel a little bit uncomfortable. And usually at that point in time, I'll do a staging laparoscopy to make sure that we don't have occult peritoneal disease. And if that's negative, then move towards a local therapy. And so I might consider radiation in that setting. I also will pretty liberally use radiation in patients who've had a history of pancreatitis, and that could be tumor-related pancreatitis or, biopsy or ERCP-related pancreatitis, because that episode of pancreatitis can substantially impact the technical difficulty of an operation, safety, duration of the operation, even feasibility of doing it. And so the longer the time that we have from that episode of pancreatitis, the better that, fibrosis gets. So I will often use radiation, and in that situation, a long course of radiation. Same with when I'm testing biology, a longer test of time to kind of give us that time before moving towards surgery. For patients who have kind of, I would say more on the locally advanced side of borderline, where I think that there's the possibility that I'll take them to surgery and I may not be able to complete the operation due to local involvement. In those patients, I also favor doing conventional long course chemoradiation, because then I know if I'm not able to do their pancreatectomy that they will have gotten a full dose. But we do use hyperfractionated radiation for some patients, and those are patients where we feel pretty confident that we're going to be able to complete the operation. It's certainly more feasible for patients, especially patients who are traveling, to be able to do a 2-week course of treatment rather than 5 weeks. And so I will use it selectively in patients with borderline resectable disease, depending on the extent of vascular involvement, if I feel like it may facilitate the dissection.
That's great. And that's super helpful. I hadn't really ever thought about the effect of pancreatitis on, I thought about the effect on the surgery, but using radiation as an extra treatment while giving you more time for that to resolve, to make the surgery better. I guess I don't think like a surgeon, so maybe I hadn't really thought about that much before, but that makes a lot of sense, actually. Okay, so the final kind of bucket of patients, before I want to get some specific questions after that for you, is locally advanced, right? So I usually quote somewhere around 25-ish, maybe a little higher percent of patients will be in the locally advanced kind of column at the time of diagnosis. Those are patients, again, pretty well established, NCCN guidelines and common practice that, induction chemotherapy is appropriate for them. And then kind of what happens after that really depends on how the disease plays out. So there have been, several prospective trials that have looked in the space at what the optimal course of action is for these patients, right? So LAP-07 was a major study that's now several years old that used kind of outdated chemotherapy with gem and gemcitabine, and that's not really so relevant anymore, but looked at the role for kind of consolidative chemoradiation. And really what that showed, again, this is, outdated at this point, but what that showed was that chemoradiation helped with time off of chemotherapy, essentially, for these patients, but didn't seem to improve survival, which I think is potentially still the case, though, I don't want to make any radiation oncologists upset, but I think, there are more modern studies. There's the LAP-100 study that recently opened. That's, a cooperative group study looking at, more modern radiation techniques, more modern chemotherapy in the locally advanced setting. So I guess my question to you is in the locally advanced patient population, presumably these are patients you're meeting, up front at the beginning, and, you might be the one telling them, or maybe the tumor board's telling them, hey, this is locally advanced. It's at present unresectable. How do you guide those patients? What's your kind of spiel about that particular population?
Yeah, and there's locally advanced and locally advanced. So even within that, there's a spectrum. There are patients where surgery is never, ever going to be an option. And that's clear because there's encasement of a long segment of the SMA, or there's encasement of the SMA into the mesentery and the jejunal arteries, where no amount of chemo or radiation is going to allow that patient to get to surgery. And then there's patients where they have encasement of the celiac, and you think about, more aggressive surgical approaches like a distal pancreatectomy with a celiac axis resection. And so I think it kind of depends on that. Some of it's that initial assessment of those ABCs, like their anatomy, their biology, their condition, is same principles apply. But if I think that they might be a candidate for surgery down the road, then again, yes, starting with chemotherapy, probably doing a longer course of chemo, even doing all 6 months in that situation. And then I would consider radiation too, potentially in that scenario. I think the role for obviously vein resections is really well established, and there's safety data that demonstrates that, it can be done safely and that the oncologic outcomes are similar for patients who undergo vein resection. Arterial resections, I think, are more controversial. And there are obviously some high volume centers that do a lot of arterial resections. We do some arterial resections here, but very selectively. I think the series that have been published do demonstrate that there is substantial morbidity and substantially increased mortality in patients who are undergoing, visceral arterial resections and reconstructions. And so I think it's really important that we continue to kind of constantly take a step back and remember, this is a very aggressive disease. And so we need to be very thoughtful about when we are thinking about offering that surgery as an option for some of these patients, because the long-term impact post-operatively, if they can get through that surgery, the long-term impact on their quality of life is really important to consider. So I think I would recommend exercising caution when considering doing very aggressive arterial resections for pancreatic cancer.
Yeah, no, I hear that quite a bit. And I guess I always think about it in two ways, and correct me if I'm wrong. So one is just that there is a lot of mortality and certainly morbidity associated with that. And also that, question is oncologically how much, like if you're having to reconstruct arteries, is that a disease we're really going to be able to cure? And I mean, is that fair to say that I think that's like a
Absolutely.
different biology, almost the ones that are tracking along the arteries? I mean, maybe that's just my simple way of thinking.
I mean, are you really clearing the disease? Do you really feel like you're going to be able to get a margin negative resection and to get, a lymphadenectomy that is going to truly clear all of that disease? And you should only consider it if you really feel confident that that's possible.
Okay, great. No, I think that's a great kind of overview of where things stand. I'll add one more to the locally advanced setting, because this is more in the systemic therapy field, is that, obviously there's recent data in the PANOVA-3 study, which is tumor treating fields. So this was a study looking at chemotherapy, and they used gemcitabine, Nab-Paclitaxel, so Gemabraxane, with or without using tumor treating fields. So this is kind of an established therapy for primary glioblastoma, where patients wear these alternating electrical fields on their head, and then lung cancer recently too. But this was looking at it in pancreas cancer. So you wear two pads, one on the front, one on the back, and depending on where the tumor is located. We participated in the study, so we had some patients on it. So, I took care of some patients who were wearing this treatment, and basically patients would get chemotherapy and then wear these for really up to 18 hours a day. And the data that was presented at ASCO this year showed that there was an overall survival benefit. Interestingly, there was a benefit to time it took for pain to worsen. And there was a benefit in both local progression and distant progression. So, it's definitely an interesting concept. I think, it hasn't, as of the time of this recording, has not gotten FDA approval yet, but, assuming it may. But I didn't know if that's something that's been, adopted. Do you know if y'all had that trial open at MD Anderson? Do you know?
We did not, to my knowledge. And no, it's not something that's been adopted. I have heard discussion about other concepts that would potentially want to test that efficacy in the cooperative group setting, but just very early, discussions about that.
Yeah, it's very interesting. I think that's kind of the classic. You got to have a conversation with the patient, right? So, if you look at the survival benefit measured in a few months, and is that question of quality of life, dermatitis risks, and having to wear this around all day, is that something that's a patient interested in doing? But I mean, obviously I'm always in favor of us trying to move that needle further. And I think this is an interesting addition to our armamentarium, and will be interesting to see the uptake and, if patients are interested in this as well for that locally advanced population.
And John, I also just wanted to briefly mention there's a NRG clinical trial that's just opened recently for patients with locally advanced disease. And it's for patients who have received between 4 and 6 months of induction chemo, and then would randomize them to ablative dose radiation therapy versus kind of dealer's choice, which could be, continued chemotherapy, observation, or conventional chemoradiation. And the goal of that is to understand if ablative dose radiation would result in improved 3-year overall survival as the primary endpoint.
Great. I think it's an area of unmet need, locally advanced pancreas cancer. So I'm glad there are multiple phase 3 studies that are working on this population, because it's a particularly unsatisfying disease status where you have someone who's not stage 4, not metastatic, but not resectable. And, I think anything we can do to help those patients is welcome. So I don't know if there are any specific kind of things you want to highlight as future directions and really any of the localized space. We talked a little bit about locally advanced pancreas cancer. I mean, I'll comment, maybe while you're thinking about it in terms of targeted therapy. I think, as I previously alluded to, looking at moving some of the targeted therapies that we either have established or we think are going to be effective in the metastatic setting and moving those earlier. So one I mentioned is the Apollo study. This is a cooperative group study that's looking at patients who complete all their perioperative therapy and chemo and surgery, and then randomizing them to olaparib versus placebo, and that's specifically for patients with BRCA1/2 mutations and PALB2 mutations. So patients that we think should be susceptible to olaparib. So that's one. Another one is, what about these pan-RAS inhibitors? So we're seeing increasing data that makes us think that this is going to be efficacious, potentially a new drug that we can be prescribing to our patients hopefully soon in the advanced pre-treated setting, and maybe even in the first-line setting, depending on how these current trials play out. But perhaps that's another therapy that we can move into the early stage setting and the curative intent setting to try to eradicate micrometastatic disease. I can talk about vaccine therapy in a second. That's another one, but I didn't know if there's anything that you wanted to highlight, maybe from the surgical end or non-surgical end.
Yeah, no, you're absolutely right. I mean, I think our goal is that we'll ultimately get to where we have more options for targeted therapies in the preoperative setting. I think the other area where we really need a lot of data is around the use, as I mentioned earlier, of circulating tumor DNA. So with CA19-9 being unmeasurable in some patients, normal in some patients, it's only a useful marker for a subset of the population. And so there really, for some, we have no idea if what we're doing makes a difference, because many of these tumors don't change on imaging. They have this fibrous, stroma that doesn't shrink on chemotherapy. And so, we see them back after 2 months, and we really don't know is what we're doing working or not. And we do know that there are some patients who don't respond to the first line therapy, ones where we do have a marker to measure and we can see that increases, or they do have radiographic progression. So we really need better biomarkers to understand response to treatment, so we can choose the right chemotherapy, change chemotherapy if the first line is not working, and understand when to stop and when to move forward with surgery. And then I think that will also be informative in the postoperative setting as well, as a measure of minimal residual disease, to understand the role of adjuvant therapy after patients have received preoperative therapy. We currently don't really have a good sense of that. So I think it'll be informative there as well as during the surveillance period. So I think there's a lot of information that we could potentially gain by having the ability to have a better biomarker like ctDNA.
Yeah, absolutely. I mean, there's, I usually think around 15-ish%, if not more, patients don't produce CA19-9, perhaps more common are African-American patients. And then, it's hard to know if what we're doing is benefiting, and that's not very satisfying as certainly as a medical oncologist, I'm sure not as a surgeon either. But so I think ctDNA is actually probably going to be the future in perhaps everyone, but, in that population especially. And, the other kind of dilemma we face often as in the medical oncology field is, patients who we give 3-4 months of neoadjuvant Folfirinox to, we get their path back, and the pathologist is like, hey, that barely made a dent. Like, there's no regression at all here. This tumor, looks as angry as it did, or that there's no fibrosis, no treatment effect. What do we do with that? Or the CA19-9 doesn't really budge, or maybe it goes up a little bit preoperatively, or, there are different scenarios in which you could say, do we change it in the postoperative setting? Do I give them now to Gemabraxane postoperatively because they didn't maybe respond to Folfirinox, or vice versa? I think that's an area that we don't know. Maybe ctDNA dynamics can help us there too, and there's kind of this ambiguity as to what the path, or maybe CA19-9 is showing us too. It's also quite unsatisfying for us.
Yeah, absolutely.
And then one thing I'll mention I alluded to earlier was vaccines. I think this is an area of active interest. And we touched a little bit in our other podcast about advanced pancreatic cancer and that vaccine therapy that's either personalized vaccine that was kind of spearheaded in MSK or kind of an off-the-shelf KRAS targeted vaccine that's more, industry looking at those for patients who have completed their therapy and, may have some residual disease that is microscopic, you can't detect it, and then giving them a kind of priming vaccine to boost the immune reactivity to any residual disease. So it's an area of encouraging early results for patients if you can get those T cells working when there's microscopic disease. We know that not everyone seems to benefit in the early studies and figuring out why those people don't, but the ones that do, at least the early results are promising that they might seem to get some real benefit in terms of disease-free survival and maybe even translating into better cure rates. So the jury's still out there, but definitely excitement in the area of potential vaccines for patients who are ostensibly NED, no evidence of disease. So that's the majority of what I wanted to cover today. I think, I appreciate you chatting with me. Just kind of some take-home points here is that pancreatic cancer is a complicated cancer and unfortunately still can be very challenging to treat for a variety of reasons. But one of the most important is that unfortunately patients present typically at an advanced stage, and only a minority of our patients are diagnosed when they still have potentially resectable disease. It takes a village. So medical oncology, surgical oncology, nutrition, psychology, social work, PT, OT, radiation oncology in many cases. I'm sure I'm leaving some people out, but to really take best care of these patients. We do know that, we didn't really talk about this, but there is data to support patients having their pancreas surgeries at high volume centers to show that morbidity and mortality at high volume centers are lower. So having access to experienced surgeons, experienced multidisciplinary teams, I think is crucial and help us provide the best care possible to our patients. And that, both of us drink the neoadjuvant Kool-Aid. And I think hopefully the data over time will prove that right. And certainly in select patients, I think it's absolutely necessary, but, maybe even perhaps in almost all patients. I don't know if you have any comments on those take-home points or any qualms or any...
That was beautifully said, John. No, I don't have a lot to add. And I hope, as you mentioned earlier, that it won't be too long before we start having better targeted therapies that we can offer patients in the preoperative setting. So again, we can avoid surgery for patients who may not benefit and then be able to test response to these new exciting treatments early. So I hope to see that coming in the future.
Me too, absolutely. Well, again, thank you so much, Rebecca, and I enjoyed chatting with you, and hopefully we got some good learning points and good discussion points out of this.
Thanks for having me, John.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.